This is weeks 4 and 5, chromosome analysis in prenatal diagnosis, infertility, and fetal loss.
The learning objectives for this week are to explain the role of various genetic tests in evaluating chorionic villi, amniocytes, products of conception, including chromosomal analysis, biochemical screening, and ultrasonography. Discuss approaches to genetic evaluation and risk assessment in individuals presenting with infertility or fetal loss.
One very important objective of prenatal diagnosis that we need to remember is that the objective is to provide the patient and the OB care provider enough information about a particular health problem to make a fully informed decision regarding pregnancy management. And it is also very important that you are able to differentiate between prenatal diagnosis and prenatal screening because far too often they're used interchangeably. Prenatal diagnosis is the term used to describe a set of tests that are designed to determine whether a specific genetic condition is present in a fetus, whereas prenatal screening is where the test is designed to determine if a fetus is at increased risk of having a specific genetic condition.
In looking at direct methods of prenatal testing collect cells and separate the chromosomes, then stain or use a DNA probe, a labeled piece of DNA that binds its complement, to distinguish the different chromosomes, or collect small pieces of DNA from the maternal bloodstream that are from the placenta and separate it. Indirect methods detect changes in levels of biochemicals or rely on clinical findings, such as symptoms or ultrasound scans associated with a particular chromosomal condition. If we look at the direct methods, the two traditional technologies that provide images of chromosomes from a fetus are amniocentesis and chorionic villus sampling, CVS. Postnatally, any cell other than a mature red blood cell, let's remember because it lacks a nucleus, can be used to examine chromosomes. But some cells are easier to obtain and culture: saliva and blood. In looking at chorionic villus sampling, CVS, during the 10th through the 12th weeks of pregnancy, chorionic villus sampling obtains cells from the chorionic villi, which are finger-like structures that develop into the placenta. A karyotype can then be prepared directly from the collected cells, rather than first culturing them as in amniocentesis. The results are actually ready in just a few days. The basis of CVS is that the chorionic villus cells descend from the fertilized ovum, so their chromosomes should be identical to those of the embryo and the fetus. Occasionally, an atypical chromosome appears only in a cell of the embryo or only in a chorionic villus cell. Chromosomal mosaicism results. The karyotype of a villus cell differs from that of an embryo cell. Clinical consequences are great. If the CVS indicates an abnormality in villus cells that is not also in the fetus, then a couple may elect to terminate the pregnancy when the fetus is actually chromosomally normal. In the opposite situation, the results of the CVS may be normal, but the fetus has atypical chromosomes. CVS is slightly less accurate than amniocentesis, and in about 1 in 1,000 to 3,000 procedures, it halts development of the feet and/or hands and may be lethal. Also, CVS does not sample amniotic fluid, so tests for inborn errors of metabolism are not possible. The advantage of CVS is earlier results, but the disadvantage is a greater risk of spontaneous abortion. However, CVS has become much safer in recent years. Looking at amniocentesis, the first fetal karyotype was constructed in 1966 using amniocentesis. In this procedure, a doctor removes a small sample of amniotic fluid from the uterus with a needle passed through the woman's abdominal wall. The fluid contains a few shed fetal cells, which are cultured for 7 to 10 days, and then 20 cells are karyotyped. The sampled amniotic fluid may also be examined for deficient, excess, or abnormal biochemicals. that could indicate an inborn error of metabolism. Tests for specific single-gene diseases may be done on cells in the amniotic fluid and are tailored to family history. Ultrasound is used to follow the needle's movement and to visualize the fetus or its parts. In looking at this slide, amniocentesis can detect approximately 1,000 of the more than 5,000 known chromosomal and biochemical disorders. The most common chromosomal abnormality detected is a trisomy. Amniocentesis is usually performed between 14 and 16 weeks of gestation, when the fetus isn't yet very large, but amniotic fluid is plentiful. Amniocentesis can be carried out any time after this point. Healthcare providers recommend amniocentesis if the risk that the fetus has a detectable condition exceeds the risk that the procedure will cause a miscarriage. Until recently, the cutoff was age 35, when the risk to the fetus of a detectable chromosomal problem about equals the risk of amniocentesis, causing pregnancy loss, 1 in 350. While it is still true that the risk of chromosomal problem increases as we hit the age of maternal age of 35, amniocentesis has become much safer since the statistics were obtained that have been used for most risk assessments. A more recent risk assessment for amniocentesis causing miscarriage is about 1 in 1,600 pregnancies, and this has led some physicians to offer amniocentesis to women under 35. The procedure is also warranted if a couple has had several spontaneous abortions or children with birth defects who have a chromosome abnormality, irrespective of maternal age. However, tests of placental DNA in the woman's circulation are becoming so accurate at detecting fetal chromosome imbalances that the more invasive techniques are increasingly being used to follow up such detection rather than being used based solely on age. When looking at indirect methods, these are methods that measure or detect a characteristic that is associated with having a chromosomal abnormality, and they're used as screening tests to identify individuals at elevated risks. These are not done to provide a diagnosis. Their use will likely decrease as more tests will be based on analyzing cell-free DNA from the placenta in the maternal bloodstream, including complete sequencing of fetal genomes. In vitro fertilization is a process used to help individuals with fertility issues. Usually, women are given hormone injections to produce multiple eggs, which are then placed in a petri dish with sperm after they are harvested from the ovaries. After about 3 to 5 days, the embryos are assessed, and a doctor, embryologist, determines which embryos are of the highest quality. Then one or more embryos are then placed in the woman's uterus. The embryos may or may not attach and lead to pregnancy. Pre-implantation genetic diagnosis, PGD, can be used during IVF when parents have a high likelihood of having a child that has a serious or deadly genetic condition. Such genetic conditions might include Tay-Sachs or adult onset disease such as Huntington's disease. Typically what happens is that a single cell is removed from the embryo at the 8-cell stage, which would be 3 days after fertilization. The genetic testing is performed. The results of the testing are used to decide which embryos, if any, to implant in the prospective mother's uterus. This slide is showing you where a cell is being removed from an 8-cell embryo, and this happens at about 3 days after fertilization. Looking at fetal loss, spontaneous abortion is the most common complication of pregnancy. Pregnancy loss has been defined as a spontaneous abortion if it occurs before 20 weeks gestation. It's defined as stillbirth when there is fetal death after 20 weeks. The causes of pregnancy loss vary depending upon gestational age. Most are sporadic, and some women experience recurrent miscarriage. If the parental karyotypes are normal and fetal loss occurs due to fetal aneuploidy, it is assumed to be sporadic with minimal recurrence risk. Recurrent pregnancy loss, which is RPL, is defined as 3 or more pregnancy losses and no more than 1 live birth. Several etiologies are implicated in the causes of fetal loss for both sporadic and recurrent loss, which include morphologic abnormalities, uterine abnormalities, immunologic disorders, and infection. 50 to 70% of the spontaneous abortions are caused by cytogenetic abnormalities. Most commonly, it's due to aneuploidy. Autosomal trisomies occur in 60% of the losses, followed by monosomy X in 20% of the cases and polyploidy in 20% of the cases. The trisomies are caused by meiotic non-disjunction. Most common trisomy is trisomy 16, and it accounts for 20 to 30% of trisomy losses seen in postmortem fetal specimens. In looking at embryonic loss, an embryonic loss refers to a loss before the development of an embryo commonly called a blighted ovum. Usually this occurs during the first 3 weeks. The rate of aneuploidy in an embryonic loss is 90%. The rate of an abnormal karyotype in specimens spontaneously aborted is higher earlier in the gestation, and it decreases as gestation increases. Advanced maternal age, if you all remember, increases the risk of aneuploidy, and low maternal folate levels may be a factor in meiotic non-disjunction, as they have been found in women who experience loss due to aneuploidy. Other genetic causes of fetal loss that have been identified are single gene disorders, such as the hemoglobinopathies, thrombophilias, and metabolic disorders. Consanguinity may also be a factor, since there is an increased risk single gene disorders if both parents carry the same autosomal recessive mutation. When multiple male fetal losses occur, a lethal X-linked dominant disorder may be suspected, and is usually associated with third trimester fetal demise. Heritable thrombophilias in women have been associated with recurrent pregnancy loss and occur because of damage to the chorionic vessels, reduced trophoblast invasion, apoptosis, and impaired uteral placental circulation due to thrombosis. Other mutations associated with recurrent pregnancy loss are hyperhomocystinemia, which is an autosomal recessive disease, skewed X inactivation, which is a hemizygous X-linked mutation, human leukocyte antigen genotype deficiency, and confined placenta mosaicism. Exposure to environmental substances can also be connected to fetal loss. Contaminants in drinking water, such as selenium, nitrates, and arsenic, are associated with pregnancy loss. Drinking water can contain byproducts of chlorine-based treatments. Other chemicals found in drinking water include haloacetic acids, monochloroacetic acid, dichloroacetic acid, monobromoacetic acid, and dibromoacetic acid. A chlorinated pesticide used in the United States before 1972 was DDT, which is called dichlorodiphenyl trichloroethane, which was shown to cause spontaneous abortion. More recently, bisphenol A, BPA, a compound used in the production of polycarbonate plastics and dental sealants, with a chemical structure similar to that of estrogen, has been implicated in recurrent first trimester pregnancy loss, and we're also looking at it as causing sterility in males. The genetic evaluation and counseling are recommended for all couples who experience fetal loss, and especially recurrent fetal loss. For couples who experience fetal loss, and especially recurrent fetal loss, it's essential to obtain a complete, detailed medical, surgical, reproductive, social, and family history that will aid in determining the cause of the fetal loss. a fetal autopsy results, maternal, paternal, and fetal karyotyping if possible, as well as a placental evaluation. You can also have screening for antiphospholipid antibodies, and you may need to refer to a support group for the parents.
Please go to the case study.